Hi everybody, my name is Dr. Masha Livitz. This is Dr. Michael Ye. We are endocrine surgeons at UCLA, and we'll be talking to you today about thyroid nodules and thyroid cancer, what you need to know. So please ask questions on Twitter using the hashtag UCLAMDchat. So for my part of the talk, I'll be talking first about how common are thyroid nodules, how do you work up a new thyroid nodule, what are the new advances in diagnosis, specifically I'll mention molecular testing. I'll be reviewing a little bit about the new guidelines and recommendations from the American Thyroid Association, and then talking about the initial treatment of thyroid cancer. Dr. Ye will then talk about surviving and treatment of recurrent thyroid cancer, and then we'll have time for questions at the end. So to start with, let's talk about how common are thyroid nodules in the population. So as it turns out, thyroid nodules are actually very common. If we were to ultrasound everybody, up to half of 6-year-olds would have a thyroid nodule. And on the illustration there, you can see the pink portion there. Let's see if I go like this. Not really showing up. So this part is your thyroid. You can see some follicles here. This is your airway or your trachea and your spine back there. So that's where your thyroid is, right here in the front of your neck. Risk factors for thyroid nodules are increasing age, females, having a radiation exposure, or being in an iodine-deficient part of the country. Thyroid nodules are also more common in women, and we need to differentiate whether the nodule is identified on physical exam or by an ultrasound. So here you can see this is a patient who has a thyroid nodule that you could feel and you could see. So that's a palpable thyroid nodule, and about 6% of women and 1.5% of men would have a palpable nodule. But if you were to ultrasound everybody, then the majority of women, 75% of women and about 40% of men, would have a thyroid nodule seen on ultrasound. And thyroid nodules are more common as patients get older. So you can see in the graph, this is the age. And again, if you ultrasound everybody, by the time you're age 80 or 90, most patients would have a small thyroid nodule seen on the ultrasound. But most of these will not be palpable, meaning you can't actually feel it in your neck. Now, the next very important point is that most thyroid nodules are not cancer. So the first time when a patient is told that they have a thyroid nodule, they immediately think, is this cancerous? And the good news is that it's unlikely to be cancer. The overall malignancy rate is only about 5%, but it is a higher malignancy rate if you're a child or if you're older. So the next question is, how do we work up a new thyroid nodule? So the important point is that, as I said, most thyroid nodules are benign. So we need to separate the benign nodules from the suspicious nodules that require further workup and potentially treatments. So as physicians, we always start with a history by talking to the patient, and this focuses first on, could this nodule be producing excess thyroid hormone? So usually those patients will have weight loss, trouble sleeping, anxiety, heart palpitations, things like that. It's also important to note whether there's a family history of thyroid cancer or any endocrine disorders in the patient or in the family that might suggest a genetic predisposition. The next important point is radiation exposure. So that doesn't include CAT scans or dental exams or x-rays. That's really, if you live next to nuclear power plants or if you had radiation treatment for something like lymphoma as a child. Now, most thyroid cancers are painless, and most thyroid nodules are also painless. So pain is not usually a symptom of thyroid nodules. Sometimes if the nodule is very large, it can cause compression. So that's usually a nodule that's over about 4 centimeters in size, and then the patient may have trouble swallowing. The next step would be a physical exam. So we'll feel the neck, we'll feel what the nodule feels like if we can feel it, and also feel for any lymph nodes. And then we'll also check the labs, specifically what the thyroid function tests are. However, the history and the physical exam alone are not very accurate in differentiating between a benign and a cancerous thyroid nodule. What is really a key is the thyroid ultrasound and the biopsy. The ultrasound is highly accurate for thyroid nodules. It's non-invasive. There's no radiation exposure. Most patients don't require any other imaging. So most patients do not need a CT scan or a PET scan or anything like that. There's a lot of benefit to the surgeon-performed ultrasound. So if a patient does end up needing surgery, it's really helpful for the surgeon themselves to do the ultrasound. You can see exactly what the nodule looks like, other nodules, the lymph nodes. That's really helpful. And there's an example here of an ultrasound, and this is the thyroid nodule over here. So these are some features that are associated with a nodule that's more suspicious for cancer. So hypoechoic means that it looks darker or blacker compared to the surrounding thyroid tissue. You can see it's a little more white. You can see some calcifications. Those are the bright white spots here. You can see that the margins here get a little bit irregular. So all of those findings would be a little bit more suspicious for a malignancy in the thyroid. We also look back to see if there's any previous ultrasounds to see if the nodule has grown and what the lymph nodes look like. So there are, as I mentioned, some new guidelines that came out from the American Thyroid Association just a few months ago, and they help us with suggesting how to work up and treat thyroid nodules and well-differentiated thyroid cancer. Now, these are just guidelines, so ultimately the treatment decision is up to the patient and the physician working together. So do all thyroid nodules need a biopsy? And the answer is no. It depends on how big the nodule is and how suspicious it may look on the ultrasound. So this is based on these new American Thyroid Association guidelines. They recommend no biopsy for most nodules smaller than 1 centimeter in size. Now, there are rare exceptions. For example, if the nodule looks very, very suspicious on the ultrasound, if there's a strong family history or a known genetic condition, things like that. But for most patients, if you have a nodule less than 1 centimeter, they recommend not biopsying and just continuing to watch it with serial ultrasounds. Nodules that are purely cystic, so this would be an example. You can see how it's completely black inside, so it's filled with fluid. Those nodules are almost always benign and usually don't require a biopsy. Now, they do recommend biopsy if a nodule is greater than 1 centimeter in size and looks very suspicious on the ultrasound. So this one looks sort of like the previous one, where you can see that there's some white spots or calcifications, some irregular margins. However, if a nodule does not look suspicious, they recommend waiting until it's over 1.5 centimeters in size to biopsy. And the whole rationale behind this is to avoid overtreatment. So this is an example of what the biopsy looks like. It's performed under ultrasound guidance. So you can see that the operator is holding the ultrasound probe. This is the needle going in to do the biopsy. This is done after the skin is locally numbed up. So it's an office procedure. It's a little bit uncomfortable, but has pretty small risks associated with it. Before we were able to biopsy patients, if you had a thyroid nodule, the only way we could tell if it's cancerous or not was to remove it. Now with biopsying, we can screen out a lot of patients who have benign nodules and not operate on them. So it's decreased the number of patients having surgery by half. These are the main categories of what your biopsy results may be. The first one is non-diagnostic. We'd rather not see this. It means that they just didn't get enough cells during the biopsy. So usually those patients require a rebiopsy. The next category would be benign. That's most results. And if it's benign, then there's a very high chance, over 90%, that it truly is benign. So those patients usually don't need any surgery and can just be observed. Now, I'll talk a little bit more about this indeterminate category. This means that there are some suspicious cells, but you can't tell that it's cancerous. And this can be a little bit frustrating, so we'll talk about that one. The next two categories are basically that it's cancerous or most likely cancerous, and we usually treat that with surgery. So this is an example of what the cells would look like from a fine needle aspiration biopsy. You can tell that they're all small, uniform in size, nothing suspicious about them. Okay, so what do we do with an indeterminate biopsy? This means that the risk of cancer is between about 5 to 30%, depending on the wording of the biopsy. Traditionally, most of those patients would have a repeat biopsy and then have a surgical excision because there's no other way that they could tell whether it was cancerous or not. And you might ask why? Why can't we tell on this biopsy if it's cancerous or not? So sometimes what you need to determine that it's cancer is to see those cells coming outside of the capsule of the nodule. You can't tell that with just a biopsy a lot of times. So this is where the role of molecular testing has come in and has really improved the care, I believe, in these patients. So our whole goal is to avoid unnecessary surgery for indeterminate thyroid nodules, meaning if your nodule is benign and not causing any compressive symptoms, we'd like to leave it alone and not operate on it. So if you look at a nodule that has an indeterminate biopsy result, the risk of cancer about 20%. So if you have surgery and it ends up being cancerous, then that was good, that was the right thing to do, and then you may need further surgery to remove the rest of your thyroid, depending on the results. However, most patients will be here, they will not have had a malignancy in their thyroid. And in that case, you've done the surgery, they may require some thyroid hormone, they, unlikely, but may have had a surgical complication or a difficult recovery. So we'd like to minimize this arm, basically. So there are some molecular markers that have been developed over the past several years, and they rely on the fact that cancer cells have a different gene expression profile compared to benign cells. So our protocol at UCLA is that whenever a patient is having a biopsy of their thyroid nodule, we reserve an extra little sample for the molecular testing. That way, if the results of the biopsy are indeterminate, we can just reflexively send off the molecular testing. The patient does not need to come back for another biopsy, and then it'll give us some more information. That's how we do it. And there are several different tests that are out there. Two of the sort of best validated ones, and the ones that we have at UCLA available, are this Afirma Veracyte GEC and ThyroSeq version 2. And the way the results are either benign or suspicious. If it's benign, then there's about a 95% chance that it's truly benign. It's almost like getting a benign biopsy in the first place, and most of those patients are observed unless they have a very large nodule or something else. If it's suspicious, it doesn't mean it's cancer for sure, but it bumps up the chance of cancer to about 50 to 80%. So most of those patients will have surgery. So let's talk now about the initial treatment of well-differentiated thyroid cancer. So a very important point to mention here is that most patients do not die from thyroid cancer because most thyroid cancers are not as aggressive as some other cancers, pancreas cancer, for example. So the mortality is only about 1 out of every 200,000 patients, and this has been stable for a long time. So these are the types of thyroid cancer. Papillary and follicular, they make up the majority. These are the well-differentiated ones that I'm talking about, and you can see the 10-year survival is very good. Medullary thyroid cancer occurs in about 5% of patients, sometimes with a genetic predisposition, also a good 10-year survival. This unfortunate patient did have what's called anaplastic thyroid cancer. That's the very, very aggressive kind. It often presents with a rapidly growing mass, very hard, often already metastatic at presentation. Those patients do have a median survival of 6 months, but thankfully that is very rare. So let's talk about the different treatment options for thyroid cancer. Usually the thyroid comes out in halves. So it's either half of a thyroid removed, which is a lobectomy, or the whole thyroid removed, which is a total thyroidectomy. So this also comes from the new guidelines. And you can see, so this is your thyroid here. So if we're doing a lobectomy, that means we're removing this half and you still have this half of the thyroid. So the new guidelines suggest that a lobectomy alone is sufficient for many patients who have a tumor less than a centimeter. Again, this is well differentiated, where the tumor is not growing beyond the thyroid into the muscle or the trachea. There's no clinical spread to lymph nodes, so there actually could be a couple of lymph nodes that have little microscopic tumor cells in there, as long as they're not large, and then no high-risk features in the family or the patient, like radiation exposure. The guidelines do recommend doing a total thyroidectomy if the tumor is over 4 centimeters in size, extending into nearby structures, if there's bulky large lymph nodes, and they specify about 2 centimeters, so that's a pretty big lymph node, or if you have distant metastases. And you can see that's the whole thyroid being removed there.
Can you go back one slide, Masha?
Yes.
Just wanted to comment. So you've got tumors less than 1, but actually there's some data to suggest, I don't know if that's a typo, but it could be up to 4.
Yeah, so that was going to be, yeah.
Oh, sorry. Keep going.
No, perfect. So anywhere in between 1 to 4 centimeters, all of this is a little bit controversial since this is all sort of evolving in clinical practice. But their suggestion is that between 1 to 4 centimeters, consider lobectomy alone.
Yeah, that's something new from the 2015 guidelines, is probably an overall movement toward a little bit less aggressive treatment. In other words, that's sort of acknowledging that maybe we were over-treating some thyroid cancers before.
Exactly right. So this is all very individualized because you have to be able to do a good ultrasound to see what the lymph nodes look like. You have to have a good pathologist to really look at the cells. Is there any extension beyond the thyroid, things like that. But it's great because it gives us the ability to do less surgery if we feel like that's indicated for the patient. And why would we want to consider a lobectomy in low-risk patients? It's because more surgery does not improve the prognosis. And we want to avoid patients being on hormone replacement. So if you just remove half of the thyroid, then about 85% of patients don't require any thyroid hormone. That's great. And then, especially if it's a lower volume surgeon, you can potentially decrease surgical complications by doing less surgery. So why should we consider removing the whole thyroid in high-risk patients? First, that there often will be little microscopic tumors in the other half. The other thing is that it enables treatment with radioactive iodine ablation. I'll touch on that in a minute. And the last thing is that how do we follow patients after they have had thyroid cancer surgery. I think you'll talk about that a little bit more, but one of the ways is with a tumor marker called thyroglobulin. You can only check that if the whole thyroid has been removed, because normal thyroid also produces the same tumor marker. So it improves our ability to have surveillance in high-risk patients. So in terms of the role of radioactive iodine ablation following surgery, there's also a movement. Just like there's a movement to less surgery, there's a movement to less radioactive iodine following surgery. So again, some points from the new guidelines. It is not routinely recommended for low-risk patients. And there used to be a time when everybody would get radioactive iodine ablation following surgery. Now it's definitely not routinely recommended. It should be considered in patients who have a tumor over 4 centimeters, some spread beyond the thyroid, or metastases to the central or lateral lymph nodes. And their only strong recommendation in the literature is if you have distant metastases in the lungs, for example, or if it's really grossly spreading beyond the thyroid. I would say in clinical practice, probably a lot of these patients would get radioactive iodine, and certainly all of these patients would. But if you have a tumor that's a centimeter or a couple centimeters in size that doesn't have any high-risk features, then there's really a movement towards not giving radioactive iodine.
Mm-hmm. Right now at UCLA, we're using it in about 35% of our patients. That's down considerably from even a couple years ago when we used it sometimes in almost all of them 5 years ago.
So I think this is my last slide. The risk of recurrence is really based on the initial extended disease. So I said that the overall long-term survival is excellent, but that doesn't mean that patients can't have morbidity associated with thyroid cancer, can really affect their life, cause problems in the quality of life, and some of that comes from a local recurrence, potential need for a reoperation that has higher risks associated with that. So the overall recurrence rate, about 15%, and the real high-risk features are if you had a really invasive tumor initially that was growing into surrounding structures, if you had incomplete tumor resection the first time, and certainly if you have distant metastatic disease. So now I'll turn it over to you.
Thanks. We might have a couple questions that came in already. Maybe you could help us, and if you want to take one or two before we move on. Sorry we were a little late, by the way.
Okay, first one.
Go for it.
Do you recommend sucking on sour candies during radioactive iodine therapy to protect the salivary glands? I actually think that's a good idea. I've heard a lot of our endocrinologists recommending that. I also recommend drinking a lot of water. It can help with sort of the radioactivity washing out sooner so that you're safe to be around your children quicker.
Yeah, basically anything to keep up the salivary flow. Once again, the question is about what to do after you've gotten a dose of radioactive iodine. Typically, our patients are isolated for a few days then, and I guess sucking on sour candies not only helps the salivary flow, but also helps pass the time when you're locked up in that room.
Okay, here's another good question.
Yeah,
so I have a 4-centimeter nodule on my left node, some smaller ones on my right thyroid. The big one has been biopsied. It's 4 centimeters. Biopsy is benign. I don't want to have surgery, but I'm worried it might be cancer. What's the recommendation?
That's a tough one. You want to take a stab at it?
Sure. So traditionally, 4 centimeters has been a little bit of the cutoff. The concern being that the biopsy is a little bit less reliable then. If you imagine a pretty big nodule, if you biopsy one portion of it, it's benign. That's great, but what if there's another portion that you didn't biopsy? So the bigger the nodule, the higher the false positive rate is. Having said that, it's still pretty low. So if the biopsy is benign, it really most likely is not cancer. You have to think about whether it's causing any compressive symptoms, because at that size, it does often cause little trouble swallowing. And so 4 centimeters is often our cutoff to recommend surgery, but most likely it would be benign. So I think there's really some room for patient decision making here.
Yeah, I agree. A lot of patients, about 85% of patients, when they have a 4-centimeter nodule or something like that, are going to have some discomfort when swallowing or sometimes some difficulty breathing. A lot of our patients with nodules that size or greater do end up having surgery. And something that we want to assess in a patient like this is a man or a woman, are they young or old? What are the risk factors for surgery? So if it's a young woman, that's probably going to keep growing over time, and also in a young patient, surgery is very safe. So we'd probably be inclined to do an operation in that patient. Yeah. So maybe I'll show a few slides,
Perfect.
and then we'll take some
Another
more
good
questions at the
questions.
end. Thanks for sticking with us. We know that any given part of this presentation is not going to help everyone, but we're just hoping to cover some of the most popular categories that people have questions about. I'm going to talk a little bit about thyroid cancer survivorship, and I want to thank THYCA, the Thyroid Cancer Survivors Organization, for helping us get the word out about this today. Now, I call this talk The Fundamentals, and I fully realize that there are a lot of emotional and social aspects that the people in the audience are more expert about than I am.
Absolutely.
So I'm just going to talk about the clinical aspects, and at the end we'll take on a few questions. I have a couple disclosures. I do serve as a consultant to these two companies. The objectives for the next 10-15 minutes or so is to talk about the prognosis of papillary thyroid carcinoma. So papillary, I'm going to stick to the most common one. About 90% of thyroid cancers are papillary in their variety. We'll talk about both survival and recurrence. These are the two clinical endpoints that we really care about. Doctor, how long am I going to live? And do I have to be concerned that this is going to come back and harm my health in the future? We'll talk about surveillance. How do we keep track of these? By that I mean scans. And then last I'll touch a little bit about dealing with recurrent thyroid cancer. And some of the people in our audience have probably already dealt with this. I know many people are concerned about this possibility, so it's important that we address this. Just an overview about the scope of the problem. If you have differentiated thyroid cancer, most people, 90%, will be adequately treated with a single operation. That forms the base of this pyramid, and we're going to come back to this pyramid a bit later on. Some people, I would say around 9%, require 2 operations. Oftentimes, the second operation will be to address a lymph node or a set of lymph nodes that may not have been fully addressed at the first time, or it's possible that it was a true recurrence, that it grew back later. And just the very tip of this pyramid are a small number of people with more aggressive thyroid cancer. Thankfully, that's the minority, and they may need more than 2 operations. And the reason we know about this here at UCLA is because we spend a lot of time doing these repeat operations. We reserve 1 full day a week to deal with people who have recurrent thyroid cancer, and it's one of our passions is to help people like that. So busy slide, just looking at survival and recurrence in papillary thyroid carcinoma. And you see here on this top graph that based on the size, people with smaller tumors have excellent survival. In other cancers, we talk about things like for colon cancer or for pancreas cancer, we talk about 5-year survival, 10-year survival, because those diseases are so aggressive, you'd rather not have one of those. But in thyroid cancer, we talk about overall survival, 10-year, 20-year survival. We have the luxury of thinking about this because in general, it's a slow-growing tumor. So even if you have a very large tumor, 4, even 8 centimeters, even the lowest number here in terms of survival at 10 years is 80%. So thyroid cancer patients do really well. Having said that, on this side, you notice that the larger the tumor is, the more likely it is to recur or come back sometime in the next 10 years. So I'm going to emphasize this point more than once. The recurrence rate for thyroid cancer will range from 5% to 35% based on a number of factors. And I don't mean to scare you, but you're going to want to know where you are in that risk profile, which we'll go over, okay? When do these recurrences happen, or who is more likely to have a thyroid cancer recurrence? So this is work from Ohio State, from Dr. Matsuferi, who passed away 2 years ago, looking at the age at which somebody got thyroid cancer here, and how likely was it that they had a recurrence, okay? So here you see this classic U-shaped curve. And I like to say that if you're going to get thyroid cancer, you may as well be a 35-year-old woman, because those people have the best prognosis. They have a very low rate of recurrence and a very low rate of cancer-related death. So the people that get recurrent disease, often a thyroid cancer growing back in the lymph node or in the lungs, more commonly in the lymph node, are either going to be very young teenagers or people over 50. What you see here, cancer death, is this black line. So even though we have teenagers, UCLA students, people in their teens coming in with thyroid cancer, sometimes in the lymph nodes, they seem to live forever. So they have to deal with the cancer, sometimes have more than 1 operation, sometimes have to deal with lymph node metastases, but they don't die from thyroid cancer. Mortality from thyroid cancer really occurs in a small group of tend to be older patients with more aggressive variants of thyroid cancer. Now you may fairly ask here, well, doc, when should if I have to prepare myself for the possibility of recurrence, when could that happen? And what you see here is most of the recurrences are detected early on, within the first 5 to 10 years after surgery. All right, so that's when our surveillance is probably the most intense. And what I'll reveal later is a lot of these recurrences maybe could be avoided if the first operation is done really, really well. And that's a key point for the second half of the talk. All right, so just a couple of slides here showing recurrence after initial treatment for thyroid cancer. And I'm just going to show on this graph from one institution shows the recurrence rate ranges from 20 to 45% depending on how patients are treated. And this graph, if you just pay attention to the white line here, shows the recurrence rate is 10 to 15%. So once again, how come we have two different studies showing recurrence rates that are so different? This one is double this one. How can that be, right? So there are biologic factors which have to do with the differences in the tumor. Also, there are surgeon factors. And it's experts who have looked at both of these articles have postulated that the surgeons in this organization, which I shouldn't name, are really focused their livelihoods on thyroid cancer and have lower recurrence rates than this institution, which had many different surgeons doing a small number of thyroid cancer operations. So the quality of the initial operation really matters. Okay, to recap, survival from papillary thyroid cancer is excellent. Recurrence takes place in 10 to 35%. And recurrence is a function, the likelihood of recurrence is a function of tumor biology and the quality of initial surgery. In some ways, I think these numbers are why THICA, the Thyroid Cancer Survivor Organization, exists, because people are happily living a long time. There are a lot of survivors who live 10, 20, 30 years, and they do think about recurrences and what's their quality of life. And so we're happy to be here to address the needs of this patient population. All right, so what are the fundamentals of how we perform surveillance for thyroid cancer? Meaning, how do we stay vigilant that if something were to grow back, that we could identify it early, that we could treat it early before it became a real problem for the patient? We use blood tumor markers, most importantly the thyroglobulin level. And Dr. Livitz mentioned earlier that thyroglobulin is a prohormone. It's the hormone that's made into thyroid hormone. It's made by normal thyroid cells as well as differentiated thyroid cancer cells. So that's why you need to have had a total thyroidectomy in order for that to be a valid tumor marker. We do use a lot of ultrasound. So you're seeing this again. Ultrasound doesn't sound that high-tech, but remember, the neck is a surface structure. It's shallow. And if you put your probe on the surface and you have an experienced practitioner, it is really the best test. We use ultrasound for about 95% of our imaging needs. Functional imaging with radioactive iodine scanning and PET scanning is, I think it's used less and less in the surveillance of thyroid cancer. We're really using biochemistry and ultrasound. Okay, busy slide, and we wanted to give you the most updated information. So Dr. Livitz already alluded to the 2015 American Thyroid Association guidelines, and these are available. The guidelines themselves, it's a bit of a lengthy document, but it is available at thyroid.org, which is the American Thyroid Association website. It's also available at THICA.org, the Thyroid Cancer Survivors Association. I'm just going to touch on this concept that's really been introduced. I have to credit Mike Tuttle from Sloan Kettering, many of you probably know of him, who talks about dynamic risk stratification. Now that's a big, long word, but all it means is that as time goes on, we learn more about the patient, we learn more about the tumor, and therefore our concept, our ability to provide the patient with a careful or accurate prognosis, like look into the crystal ball of their future, that gets clearer with time. All right. Now, if we meet a new patient tomorrow, they just had a biopsy that's concerning for thyroid cancer. They want to know, Doc, how am I going to do? How am I going to do? And we can tell them something on that day. But 3 months later, we have more information. 1 year later, we know even more. Okay? So that's all this means. A lot of people have excellent response, meaning after initial treatment, surgery with or without radioactive iodine, then you can't see, they have an ultrasound at a year that's totally blank. There's no evidence of disease regrowth on the ultrasound, and they have a thyroglobulin that's undetectable. I mean, sure, everybody wants to be in that boat where they have no evidence of disease. Not everybody can be in that boat, but I just want to make sure that most people out there know that a lot of people have what we call biochemical incomplete response, which means we can't see anything on ultrasound, but they have a little bit of thyroglobulin floating around in their bloodstream. And if there's one message I have for the survivors audience is that please do not worry too much about that, because most people with thyroid cancer, many people with thyroid cancer, live long, healthy, full lives with a little bit of thyroglobulin in their bloodstream and die of natural causes when they're 80 or 90. But I am aware, I'm sensitive to the fact that it does cause some anxiety. So we're going to address that. Now, a small number of people have what we call a structural incomplete response, which means even after initial surgery, there is tumor that we can see. on imaging, usually an ultrasound or a CT, or even at the end of surgery, sometimes their surgeon will say, I wasn't able to remove all the tumor. And those are the patients who we're quite a bit more concerned about. Okay, so once again, we'll go back to this pyramid, and the base of the pyramid, again, excellent response or biochemical incomplete response that resolves. Many people with initially a biochemical incomplete response have some detectable thyroglobulin. If you leave them alone, or sometimes they need additional treatment, some people would have a second dose of radioactive iodine, which we tend not to use. They will eventually prove themselves to have an excellent prognosis. That's the base of the pyramid, the blue part. And the top part, really this top 1, at most 10%, those are the people with structural disease recurrence, something we can see, a target we can see on an ultrasound, and those people are the ones who need a little bit more treatment, a little more help. We tend to see a disproportionate number of people like that at UCLA because we're passionate about treating people with that sort of complex level of disease. I'm going to talk to you about a little bit about our surveillance protocol, what we do here at UCLA. We see everybody at 3 months after surgery, and we have some questions for them. We want to know, did you have radioactive iodine or not? Again, there's a trend toward using less radioactive iodine. And we did talk about the ATA guidelines, but I wanted to advise, it's very important for the patients in the audience to know that these are very newly published, and the degree of acceptance of these new guidelines is going to vary from endocrinologist to endocrinologist. And it's something you should be aware of if you approach your physician with some of these new data. At 1 year after surgery, we have a surgeon-performed ultrasound. So I personally do the ultrasound in all of my patients with thyroid cancer. Dr. Livitz will do the same. We have an advantage. We've been in there. We know what we did. We have detailed notes, and so if there's a recurrence, we would be the most likely to see that early. And then we measure, by then we usually have several thyroglobulin levels, and we obtain a stimulated thyroglobulin level on virtually everyone at 1 year. And for those of you who are new to this topic, a stimulated thyroglobulin is something you get when the patient's TSH is high. All right, so TSH is a hormone made by the pituitary, and it's basically a more sensitive way of looking at thyroglobulin. There are 2 ways to achieve that, either by stopping thyroid hormone for a while and letting the TSH naturally rise, or you can give injections of recombinant human TSH. Now, after 1 year, I'm going to show you that most of our patients are disease-free, and we follow that quantitatively here at UCLA with our quality dashboards. And so there are some patients, at that point, we will return them to the surveillance of their endocrinologist, and others who we might think have a higher likelihood of having a recurrence, we'll keep them a little closer to us. So if there's any hint of a recurrence, we'll be on top of that. Okay, real quick, this is a slide. This is Mike Tuttle's slide talking about dynamic risk stratification, and he and I were sitting in the back of a cab a few months ago, and we started to talk about this concept that as the time goes on, the patient's prognosis becomes comes closer and closer into focus, sort of like a photograph. And he ruthlessly stole my idea and ruthlessly showed it at a national meeting, so I am ruthlessly stealing his slide. I feel right in doing that. But essentially, as time goes on, as we get to the 3-month mark and a year mark, we have a much clearer picture of the patient's long-term future. If you have a negative ultrasound and an undetectable thyroglobulin at 1 year, the likelihood that you're going to have a significant clinical disease recurrence falls to less than 1%. And so we love to give patients that sort of get out of jail free card. Just go live your life. It's not going to be a problem again. That's often a very happy day, that 1 year mark. So a couple scenarios. The first scenario, complete resection, negative nodes, or microscopically positive nodes, just a few little specks of tumor. That's about the same. The microscopically positive nodes is not, we haven't been able to prove that it's worse than negative nodes. On 1 year surveillance, we have an undetectable thyroglobulin and an ultrasound negative. Everybody wants to be in that boat. It has the best prognosis. Okay, so a lot of you may be fortunate to be in that scenario. Here's another scenario, just slightly different. Complete resection, negative nodes or microscopically positive nodes. This is a low-risk patient. And at 1 year, the ultrasound is negative, but we have a little bit of thyroglobulin that's detectable. Okay? Lots of people are in this boat, lots. And oftentimes there's a lot of anxiety. There's a little bit of thyroglobulin lurking around. Remember, thyroglobulin is not harmful. It doesn't hurt the patient in any way. And a lot of these people have an excellent prognosis. They're going to go on and live long and healthy lives. We're going to have some ongoing surveillance of them. But the likelihood of those people needing a reoperation is actually quite low. Different scenario. Complete resection with macroscopically positive nodes, or you could say what's an invasive tumor. You're about T3 and T4 invasive tumors, or nodes that are visibly abnormal or visibly abnormal on ultrasound. At 1 year, a lot of these people have a negative ultrasound, assuming that the first operation was done to clear all those nodes that were abnormal. And a lot of them will have a thyroglobulin that's detectable. For instance, a lot of our patients who present with lateral neck disease, who need lateral neck dissection, a lot of them, majority of them, are going to have some detectable, a small amount of thyroglobulin. Again, these people still have a very good prognosis, and they have a small chance at reoperation. Do you want to comment on this group of folks?
Yeah, I would agree with exactly that. I think, at some point, if there's a couple of, it's often about the biology of the actual tumor. If it's already sort of clinically spread to those lateral lymph nodes, it's kind of telling you a little bit about its biology. And at some point, there might be a little bit of tumor that decides to grow back in a lymph node. Still very unlikely to have distant metastatic disease, which is what I think a lot of patients worry about.
Yeah, so we like to say that if there is some lymph node in the neck, we can manage that.
Right.
We can do operations to fix that. Sometimes when thyroid cancer gets outside of the neck into the bones and lungs, that becomes a little harder to treat. Here's another scenario, a complete resection with macroscopically positive nodes or an invasive tumor. And at 1 year, if we can find some thyroglobulin, and what's different about this scenario is that the ultrasound is positive, so we see something on the ultrasound. And if that's the case, this patient will likely need a reoperation. So once again, I want you to conceptually separate structural positive disease or structural incomplete response. Those people need a little bit more work. Same goes for this scenario where if you have an incomplete surgical resection, those people, we try to give them additional therapies like radioactive iodine, sometimes targeted therapies, and these are the patients we're going to have very close to our chest to make sure that we manage them carefully. I should mention scenario D. Some of you are probably in this boat, people with positive anti-thyroglobulin antibodies. So these are antibodies made by the immune system present in somewhere between 10 and 20% of people with differentiated thyroid cancer. Now, normally we use the thyroglobulin, that pro-hormone level, as a tumor marker. However, some people have an autoimmune response against thyroglobulin, and that makes it so we cannot use that test as a valid marker of the presence of tumor. Okay? Let me say that another way. So if you're like 90% of people and you have no antibodies that would interfere with the assay, if that thyroglobulin level is 0, you have confidence that that is accurately measuring that you have little or no tumor in your body. However, if the antibodies are there, they cause some confusion, and therefore that thyroglobulin indicator is not as helpful. In the real world, the way to think of it is we become highly dependent on imaging in this group, right? So then we only have one of our two tools. There is a literature looking at thyroglobulin antibody levels and measuring those as what we call a surrogate marker of disease. So if you can't use the thyroglobulin, does the antibody level going down mean a good thing? So as a surrogate marker? Now, the literature on this topic goes back and forth, and the best I can tell you is if you have antibodies, if you're in that 10 to 15% who have antibodies, and the antibody level is going down, that's probably a good sign. Probably, though not as reliable as the thyroglobulin itself. And if that level is staying the same or going up, it may indicate the presence of additional tumor. But once again, the data is really not that crystal clear. Okay, so this is a question I often get from THICA patients, thyroid cancer survivor patients. So I thought we would discuss it. What is the path that leads to reoperation? So some of you may be at home worried that if there's some thyroglobulin around, does that mean I'm going to need another neck operation? So let's talk about that and how you get there. A little bit of a complex flow chart, but oftentimes the way we start is the first thing we see is the elevated thyroglobulin. And the way to remember this is the thyroglobulin is so very sensitive. It's like a fire alarm that can pick up a guy smoking a cigarette 2 doors down. It's a very, very sensitive assay. So once there's a blip or a rise or an unacceptable level in the thyroglobulin, that in and of itself won't make us do anything. Remember, we have to have a target, all right? So we need something structural, usually on an ultrasound, to be visible. And then we go through this process that we ask the question of identity, which means, okay, you have a thyroglobulin of 8, and you have a 1 centimeter structural abnormality on ultrasound. Do I believe they're one and the same? Do I believe that area of tumor recurrence explains the thyroglobulin? Because if there's another patient in whom I can see a little lymph node, but the thyroglobulin is 500, it doesn't match. Does that make sense? It doesn't match. That patient's going to have disease outside of that lymph node. So we have to ask whether or not, and what's our goal? We want to take that thing out, have the patient be free of disease, and have the thyroglobulin fall. In our dream scenario, that's what we want. We don't always achieve that, but that's our goal. So if we think we have identity, sometimes we'll do an FNA, put the needle in that little bit of tumor to prove that that we have living tumor cells in there. And then there's a discussion between the patient and the surgeon. If we're going to do a reoperation of the neck, we don't rush into these operations. We have to think about what's the risk and the benefit. As surgeons, I think maybe that's our most important job. Is it worth it? Because if we do an operation, there's going to be risk. That's for sure. What benefit do we hope to get out of it? Are we prolonging the patient's life? Are we improving the quality of life? And if and only if we can prove that there's some tangible benefit that's worth the risk, then and only then can we reoperate. So, and sometimes we decide that the risk-benefit ratio is acceptable, and sometimes we decide it's not acceptable, and we go back and we resume surveillance. And we do have patients in whom we know they have a small amount of cancer, it's not hurting them, and we continue to watch them year after year, and it doesn't grow. Sometimes in these patients, if it grows a little bit, we'll decide to operate. But thankfully, most of these thyroid cancers are pretty slow growing, so we have the luxury to think about this decision. And the message I have to you is don't rush into any reoperation. You want to comment?
I agree completely with that. Yeah. Do you want to mention the role of PET scanning or anything in there? Because I think a lot of patients ask about that
some
question.
questions about PET scanning. We don't often use PET scanning. It's a functional scan. PET scanning looks at the amount of glucose consumption by the tumor. And thankfully, because most thyroid cancers are slow growing, they usually don't take up the PET isotope. A subset that do tend to be more metabolically active. They're using a lot of energy, and so they may be more aggressive. But I would say at most only 2 or 3% of our patients ever get a PET scan.
Yeah, and a caution of getting a PET scan too early from a prior surgery. There can be a lot of reactive lymph nodes. Even an ultrasound also, if it's too soon from the time of prior surgery, you can have a lot of false positive reactive lymph nodes. So just a caution there.
Oh, that's a great point. Yeah, so after surgery, surgery is an injury. The body has to heal,
Yeah.
and those tissues are going to consume glucose, so you can get a lot of false positive scans. So after any operation, we wait at least 6 months to let the neck settle down and heal, because before then, it's hard to see much of anything. It looks like a swirl of healing tissues. So a message you're probably getting from my slides is when it comes to thyroid cancer surgery, that first operation is the best chance for cure. Every day we're seeing patients who had an incomplete initial operation, and then it's hard to play catch up after that. We would rather the patient have an initial operation that was just perfect. And what we like to tell our residents and students is that this is a pivotal day in the patient's life. You know, I just confess, as a surgeon, we come into work and it's Tuesday, or Wednesday. It's a day at work, and it's our job to remember that for the patient whose thyroid cancer operation is that day, this is the day for them. This is the big day, and we have to forget about all those other things that are going on in our lives and really dedicate ourselves to make sure that we do the best operation, and that could set that person free. You could literally cure more than 90% of patients if you just do a great job that day, and we have to hold ourselves to that standard.
Yep.
So we are reliant on excellent preoperative imaging, right? So we do all the ultrasounds ourselves. There are many operations on patients who had failed operations, usually elsewhere, where the imaging, they didn't even have a correct map of what was going on. There were positive lymph nodes that were there that they missed. So if the quality of operation is totally contingent upon the quality of your imaging. And at UCLA, and this is a trend across the country, endocrine surgeons have really taken ownership of that imaging, the surgeon doing that ultrasound themselves. You want to comment on that?
I just think that that's so important. That's really important, because if you have a radiologist who's doing the ultrasound and they may say there's a lymph node in left level 3 here and go after it, and you can't do that ultrasound yourself, you can't feel that lymph node, I just think it's so much harder to really clear that compartment. So to be able to see that yourself, I think is really critical.
Yeah, so we do ultrasound twice on everybody. We do it for all of our thyroid cancers on the day we meet them, and then when they go to sleep for their operation, we do it again. At least for me, it allows me to create a three-dimensional image, fresh in my mind, of what that patient needs. What's the roadmap to that patient's operation? And for us, I really think sometimes I can't, it's hard for me to imagine how I would do that operation well without the ultrasound. I would feel like I was flying blind. So we're really quite dependent on good ultrasound. So We perform methodical surgical clearance of all detectable disease. Compartment-oriented surgery means when we take out a lymph node, we don't just take out the node, we take out an entire block of tissue. So if there's a house on fire, we don't just address the house, we address the whole city block. Because if there's one that we saw that was abnormal, we have to assume that it's got little buddies there next to it that are also abnormal. And I want to say this alone, this operation alone, without anything else, is usually adequate treatment for most patients. And even Mike Tuttle, even though he's not a surgeon, he would admit that this is a surgical disease. And sometimes when I give lectures to other surgeons about this, we talk about radioactive iodine, we talk about all those follow-up treatments, and I tell them, hey, there's no amount of radioactive iodine that's going to make up for your sloppy operation. I hate to say that. It just has to be a perfect operation. I'll just wrap up by telling you about a case. I know we're running long on time, so thanks for sticking with us. This is a 55-year-old woman I first met in 2009. She had positive nodes. So she came to see me, and I saw on my ultrasound that she had positive lymph nodes in the central neck, here in the middle, and also she had positive nodes in the side, the lateral neck. So she went to another institution for surgery, and she got what they called a lymph node mapping. So they looked at the lymph nodes there. And she had an operation somewhere else, had a total thyroidectomy and neck dissection, and afterward, her thyroglobulin was high. Okay? So she had macroscopically positive lymph nodes, and she had a biochemical incomplete response, and a couple years later she came back to see me, and I'll tell you what I found. So when I saw her in 2009, here's her thyroid, she had this abnormal lymph node, here's the carotid in the lateral neck. Okay, that's a macroscopically positive lymph node. So this lady is a high risk for recurrence, high risk for reoperation. And there you see it again, a very fat lymph node, it's got little chunks of calcium in it, it's clearly abnormal. So she comes back in 2014, and I ultrasound her again, and you know what? That abnormal lymph node was still there. So the other institution did not remove that lymph node. They did an incomplete operation. And this thing continued to grow and continued to make thyroglobulin, and then it actually grows kind of slowly, right? 4 years, it's only like, I don't know, 50% bigger. But this just goes to show that if your imaging is not good, and if the surgeon's not, doesn't have the mindset that they're going to own that imaging, you're going to leave disease behind. And this was a clear example of disease left behind. Anyway, so we went back and we cleared that, and now she's disease-free. And this just goes to show that I think we're privileged as surgeons. We get to do an ultrasound and then unwrap this mystery box and then see if we were right. And then the next time we do an ultrasound, we could be better because we learned from the last case. And so we do this thousands and thousands of times, and it makes us better at doing the scan.
Yeah, that immediate feedback is really helpful in that process.
Yeah, so we're, just like you guys, we're developing ourselves. We want to be better every day. This is one of our quality dashboards, and what this means is a very small font, but every quarter we get a printout from our information technology, medical informatics service about all the thyroid cancer patients we operated on. How often did they get radioactive iodine? How often did we check a thyroglobulin on them? How often were we doing it by the book? And we also show our results here, and this was about a year's worth of data from 2013 to 2014, showing that of all the patients we operated on with thyroid cancer in that 1 year period, only 1.9% of them needed another operation within a year. And that's, you've got to measure your quality if you're going to really be serious about it. And so we're proud to offer this level of care. We're always scrutinizing our own outcomes. And when we say we're going to offer it a certain level of quality, we want to back it up with the numbers to show it. Okay, just to summarize, most papillary thyroid cancer patients live long, healthy lives, thankfully. And I know I haven't addressed the other cancer subtypes. We might reserve that for another day. Many of these patients have detectable thyroglobulin levels. Please don't let that keep you up at night. It's important to have good surveillance to catch those recurrences early and deal with them early. The pathway to reoperation, there are a lot of hurdles you got to get through, okay? You have to have an elevated thyroglobulin, you have to have a target, and then it has to be worth it in terms of the risk-benefit discussion you're having with the surgeon. Good initial surgery for thyroid cancer is the best chance for cure, that really important day in the patient's life. And it's worth being fussy about ultrasound exams because everybody does them a little differently. And a lot of places you can't always have a doctor do your ultrasound. Some places there are technicians who do them. We have a lot of very good technicians. But I just think when it comes to thyroid cancer, so much is riding on the quality of the ultrasound that I just feel like I need to do it myself. I just can't accept it. Yeah. So that's what we have. Please feel free to tweet in your questions to UCLA MD Chat. And I think we do have some more questions. So maybe we'll take a couple more. Thanks so much for paying attention to our broadcast.
Let's see. What are the biggest risk factors for developing thyroid cancer? So I'd say a couple would be radiation exposure, especially childhood radiation exposure, like having a childhood cancer that required head and neck radiation, and then a family history of either well-differentiated thyroid cancer or an MEN history that might predispose you to medullary thyroid cancer.
Yeah, I agree. So the thyroid, in children under the age of 15, the thyroid is susceptible to certain genetic changes brought about by radiation. So we do see survivors of the Chernobyl nuclear disaster here. We have yet to see anybody from Fukushima. The Japanese nuclear power plant released much less radiation than Chernobyl, thankfully. And then here at UCLA, we have a large group of children who were treated for lymphoma as kids, and the radiation was part of their treatment. And they sometimes develop thyroid cancer as a secondary effect. It is because they were treated and the treatment caused a new cancer. So I think radiation and family history. And then we do have some people who grew up in iodine-deficient areas who migrate to Los Angeles. So here in Los Angeles, we have large groups of Iranian and Armenian immigrants, and those parts of the world are deficient in iodine. So if you have iodine deficiency in childhood, it can predispose to thyroid cancer later.
This is an interesting question. How easy is it to tell apart a parathyroid tumor from a thyroid tumor based on imaging? So that's a great question. So I would say if you are, and we have another webinar about parathyroid disorders that I would also refer you to, but the first step in diagnosing a parathyroid disorder is the laboratory test. So a high calcium, high parathyroid hormone level. If you don't have biochemical evidence of hyperparathyroidism or parathyroid adenoma, then I would not be looking for anything on imaging, because that imaging is very likely to be false positive in that case. So don't worry too much about that unless you actually have the laboratory tests. The next step in terms of the imaging is that usually parathyroid adenoma is adjacent to the thyroid. So you see sort of a separation between the thyroid itself and the parathyroid. You see a little plane in between there. And we do have some additional imaging for parathyroid disorders, sestamibi scan, 4D parathyroid CT scan, that can be helpful.
Yeah, I agree. So just to reiterate what Dr. Livitz said, if you're looking for an abnormal parathyroid, it's less about the imaging and more about was your calcium high on the blood test before. Okay, so I hope that helps. So in endocrine surgery, we tend not to jump to imaging. We tend to really scrutinize the history of the patient, what's going on with the blood test, and then we sort of proceed methodically down this path instead of jumping right into looking for structures and things like that. Dr. Clark, my teacher, always said, remember, Michael, we don't treat x-rays, we treat patients. So we rarely respond to an image alone.
All right, so you want to try this one?
Okay. Oh, that's a good one.
Yeah.
If thyroid nodules have such a low mortality rate, why should I pay to remove them? That's a good question. So we would agree that we want to try not to operate whenever we can. In medicine, this sounds like maybe an engineer or a business person emailing us. But in medicine, we don't deal with tests that give us a certain answer. We deal with probabilities. And we have to make decisions based on imperfect information. And what that means is, in a way, we're kind of gambling, right? So if we do a biopsy and it shows it's suspicious for cancer, we could not do anything and gamble that it's benign. But if we're wrong, maybe it's a pretty high stakes gamble, right? So a lot of times we take the safe gamble. We do an operation that we know we can do safely, and sometimes it ends up being benign, or as the participant says, maybe it was so low mortality that we didn't need to do it. Maybe. However, what about that small chance that it isn't one of those low mortality rate cancers? It's really hard sometimes to predict which cancer is going to be the slow growing one and which one's going to be the real monster. Sometimes it's hard to know until you have that 1 year of information to see how they responded to initial therapy. So it's a great question. I'm not sure we'd have too many people volunteer to just do nothing about their thyroid cancer. So this has been attempted in Japan. There was a study in Japan where they had some older people with known thyroid cancers, and they just watched them. And if some of these patients were like 70 or 80, you know what? They died of something else. They died of something other than thyroid cancer. But it turns out in younger people, they tended to progress and give off metastases and start to act in a dangerous fashion. So we tend to be aggressive, particularly in patients who are otherwise young and healthy. Sorry for a long answer. Go ahead. I'm curious what you want to say about that.
Yeah.
It's a philosophical question.
It really is, yeah. I think there's a risk-benefit ratio for every patient, and I would agree that if you have an 80-year-old patient with some heart disease who has less than 1 centimeter thyroid cancer, and you want to get an ultrasound in 6 months rather than operating on that patient, I think that that's a very valid, point to bring up, and something that as a patient you could really consider. But more of our patients are young, healthy patients. So the question is, if you were to leave even that small little thyroid cancer that we are telling you is not going to kill you, let's say if you leave it for a year and then you come back for your ultrasound and now you have multiple positive lymph nodes, and then you have to have a little more surgery, you have a higher risk of recurrence. We don't want that to happen. And I think we're still, as a community, doing a lot of studies to see how far we can push this towards being less aggressive with the treatments. But overall, we're really concerned about your safety first, our individual patient that's in our clinic. And we don't want to gamble and potentially have the patient, risk having a worse prognosis by not having the treatment. So that's the main reason.
There's definitely a sweet spot here. I mean, we don't want to do too much surgery. We don't want to do too little surgery. We just want to do the right amount of surgery for the people who need it. There is a sweet spot there that we're after. Yeah, go ahead.
Yeah.
It's a good question.
It really is. Yeah, let's see. Oh, okay, so the thyroid makes hormones that regulate metabolism. How can one live once the gland is removed?
Excellent. Yeah, go for it.
Yeah. So the great thing is that we have gotten really good at replacing thyroid hormone with thyroid medication called Synthroid. Now, most patients, once you remove the thyroid and are placed on thyroid hormone, really do very well. They have a normal quality of life. They don't have problems with their weight, with getting pregnant, with all kinds of things. They really are just like any other normal patient, most patients. I am aware that there are some patients who don't feel well on this thyroid hormone medication. I don't want to discount that because there are some patients, even if the thyroid function is normal in the laboratory test, still don't feel well. And then there's some room to play around with different forms, T3 versus T4 replacement. I would say the most important point there is to have a really good relationship with your endocrinologist. You need an endocrinologist who will listen to how you're feeling, take into account your symptoms, as well as the objective data from the laboratory test to make decisions with you on how to adjust the dosing. And there's some room for adjustment in those patients. And I recognize that that can be a little bit of a struggle for some patients. But most patients do very well and just have a normal quality of life with replacing thyroid hormone. And there's really not any side effects as long as the dosage is the right dose for you.
Yeah, so I would echo that comment. It's good to have help, good to have professional help, have an endocrinologist who you have a long-term relationship with. And most people, so thyroid hormone, the nice thing about thyroid hormone is it's one of these very slow-acting hormones. It's a nice, easy ride. Maybe you have a friend who's on insulin. Insulin's the opposite, where it has to be regulated minute to minute. It's very, very fussy. But you take a tablet of thyroid hormone, it lasts for a month. So it's almost like flying a hot air balloon. We make small adjustments, and then we wait a month to see where the level reaches a steady state. And again, 90% of people have a normal quality of life, a normal metabolism. We ask patients if they're feeling tired, gaining or losing weight. A lot of people worry about gaining weight if they're on thyroid hormone. Usually that's not a problem. What we tell most people is weight gain really has more to do with diet and exercise behaviors in most people. So if people are good about taking their thyroid hormone regularly at the same time of day, have a routine for doing this, they do fine. I want to advise the audience that thyroid hormone is the second most commonly prescribed drug in the country. There are millions of Americans on thyroid hormone out there, living their lives, paying their taxes, and most of them do fine. And there are a small percentage that need a little bit more attention. This is probably 5 to 10% of their overall population. Do you want to take one more?
Let's see. Okay, so how often should you follow up a nodule with ultrasound to make sure that it's not malignant? So if, I'm going to sort of transform this question just a little bit to make it a little more generalizable to the population. So let's say you have a thyroid nodule that's been biopsied that doesn't require any surgery. When should you get the next ultrasound to make sure that it's not cancerous? I would say traditionally it's about once a year. If you have a benign biopsy, about once a year. Sometimes if it really looks pretty suspicious or something like that, it's the first time we're seeing it, we may want to get a 6-month ultrasound. But it's very rare for a nodule to change within 6 months. Usually 1 year's time is actually very safe. And the new guidelines even suggest every couple of years, depending on what exactly the nodule looks like. So I'd say roughly once a year.
Yeah, so again, in medicine, we don't have any tests that are 100% accurate, right? So a benign biopsy is one of the best tests we have in medicine. It's highly reassuring. It's a 95, 96% chance that that nodule is going to be truly benign. That said, there is that 4% false negative rate. So that's why we do want to follow at least with one more ultrasound in a year to make sure that we don't miss anything. And certainly, if you're one of those people and you feel that your nodule is enlarging or something is new or it's bothering you or sometimes your voices change, come back in. We want to be sensitive to the changing landscape of a patient's symptoms. So if anything changes, go back and see your doctor. The internet's great. I love think about this all the time. The internet's great for these things, and of course we want to help you. But you're out there. We haven't met you. We haven't felt your neck, and so that's why you're always going to need a doctor. You're always going to need a doctor who knows you. And if there's any advice I would have for you is know the limitations of internet-based medical information, and there's no substitute for a good doctor you trust. Any closing points?
No, I mean, I hope that what we've said is helpful. We really enjoy discussing the subject and seeing patients. I think one of the reasons that I really enjoy endocrine surgery and thyroid is that most patients really do very well, and it really is very rewarding to be able to remove a thyroid tumor and to have patients just live the rest of their life with a really good quality of life, and that's a really personally rewarding, great part of the job.
I agree. So we're going to wrap up. We welcome your feedback. Please write in comments and questions, and we'll use that to design the next webinar if you can come up with your top questions. So thank you again for your attention.
Thank you.
Bye.